Welcome to another episode of the MEGIN Spotlight series. Today we are delighted to have Dr. Steve Allder, a consultant neurologist at the Cognition Health Brain and Mind Experts, as our guest. Cognition Health specializes in the diagnosis and treatment of a wide range of conditions such as autism, Alzheimer's disease, Parkinson's, and traumatic brain injury. Hi Steve, thank you for joining us today.
Hi, nice to be here.
Let's start with some information about how you became familiar with MEG. What started your interest in MEG and how did you come across the capabilities of MEG?
Well, that's a very specific and niche answer. The problem that I was grappling with was that I was being sent a lot of patients with mild traumatic brain injury. And as I started to see more patients, I realized that this is a pretty controversial condition. And what I mean by that is that because people are not certain how the symptoms are generated in the brain, there's a big debate about whether or not the problem is an organic problem, which I think would mean that patients would get a lot of sympathy and support, as opposed to a psychological problem, in which case I get the sense the paradigm is you sort of lazy good for nothings. What are you doing? Being weak-willed and having all these types of symptoms. So there's kind of far less sympathy and support on offer. Now, my own sort of starting point was that I was kind of vaguely aware of this debate. But as I started seeing more and more patients, I started to come to the view that the vast majority of the people that I was seeing did have what looked, from a clinical perspective, like a more organic problem. Now, there definitely were some patients who had a more psychological aspect, and there was a small proportion with a mixture of both. But what really struck me were several things. Was firstly, the symptoms, even though they were subtle, really, really affected people. So if I compare the work that I did with acute stroke, and so with acute stroke, you have an obvious problem with the brain. But the way an acute stroke affects people seemed to be less of a problem than how this mild brain injury was affecting people in terms of the whole life. So I then was sort of in the middle of this thinking how to move forward. And what I needed was some imaging or diagnostic modality that would resolve the debate. And previously, I've done work with different types of MRI, different types of PET scanning. And given how contentious this was, we needed something that at an individual patient level would be really clear. And I just really did not feel that either MRI or PET was going to be able to bring the clarity we needed at an individual level. And the MRI physicist that I worked with when I was doing my first research had gone to the States and was running a clinic using different types of MRI. And we met up and he told me his experience with using the most detailed MRI. And he said, you're never going to get it at the moment to individual level. So in many ways, I'd almost given up. And again, I'd like to say at this point that I was doing lots of detailed reading around the subject. But actually what happened was someone, by mistake, sent me an email and it had MEG and TBI. And as I was kind of working through, that email just came back to me. And I literally was driving along and I stopped the car and I got my phone out and I looked that email up and there it was, MEG in mild TBI, with potentially the ability to give you a yes/no answer at an individual level. And then weird things happen. So somebody who had been training when I was a consultant where I was working previously contacted me on LinkedIn, and he unbelievably was doing MEG research in Oxford. And he'd just been to the States and seen the lead author of this paper present. So I said, oh, that's weird. You should reach out now. And he said, yeah, no, it looked really good. So he sent me the papers. And I had a look at them and I said, wow, this looks really exciting. So I said, well, if I didn't want to use MEG in this country, where would you suggest I go? And he said, well, if you want to use it in clinical patients properly, rather than, doing it in MEG centres that are more academic, where people keep taking the machine apart and doing new paradigms with it, there's two places, Cardiff and Aston. So I literally looked on my map from where I am and thought Aston looks closest. And that was how I discovered MEG and the journey began. And that was probably the end of 2016.
So how incredible that this chance email took you down this route. Fast forward from that, let's talk about the present. Which conditions are the primary focus at Recognition Health when utilising MEG, and why?
Yeah, so at the moment, there's a very specific focus on mild traumatic brain injury, so the mildest group. And the reason that we're using it is we're trying to bring clarity to the question, what is going on in the brain of the person with these symptoms? And that in turn then starts to answer the question, have these people got a subtle damage to the brain tissue which is causing the symptoms, or have they got a more of like an emotional injury that's changed the way the brain is linking up together? And we're finding that MEG is very well suited to answering that question.
This is really interesting for our viewers. You've mentioned TBI as one of the conditions you focus on. Are you able to share any specific cases where MEG has assisted in diagnosing a patient with this condition, and what's been the outcome for that patient?
Yeah, no, so I can give you two examples, both. And the first thing that illustrates is kind of this type of condition can affect any of us. So the first is a young woman who is a doctor working at a consultant level, and she was doing a charity bike ride, and unfortunately, I think hit a pothole and then came off and went over the handlebars and landed on a helmet and had a mild traumatic brain injury. And she was attended to on the roadside. Then she went to the emergency department, where she was on somewhere between Land's End and John O'Groats. I think it was somewhere just outside Wales. Then they went to the emergency department. They checked her over. Someone came and picked her up and took her home. Kind of ruined her charity ride, but she thought, I'll be okay. I've got a bit of a concussion. I'll recover. Anyway, so I then am asked to see her probably 2 years down the line, and this young woman who's working at a very high level at a very senior job just can't go back to work. And the people that she's seeing, and by this stage it's a lot, recognise there's a problem, but she's got no clarity at all about what has happened. And even though she's completely normal, she's fallen directly off a bike onto a concrete floor and hit her head. The clinicians treating her say, we don't really understand why now you have got this set of symptoms, and why that in turn is then affecting your ability to kind of go back and carry on with the career that you've spent 20 years training towards. And what MEG can do in that situation is we can do a 10-minute scan, we can acquire the data, we can analyse it, and then we can show, and in her case, depending on which frequency band you look at, we can see 4 or 5 clear areas in the brain where the frequency abnormalities suggest that she's got patchy structural injury through her, to a sort of a microscopic cortical injury through the frontotemporal lobes, which is kind of what you would expect from an acceleration-deceleration brain injury. And in association with the abnormalities, we can see that she's got abnormal connectivity. So the bits of the brain that are injured are all overconnected, which is probably the brain trying to compensate. But that just brings so much clarity to her as an individual, kind of saying, well, what's wrong with me? And that in turn brings clarity to all the clinicians involved. So it's difficult for me to think of a condition I've been involved in as a clinical doctor, as a neurologist, where a diagnostic test is potentially so helpful.
It's great to hear that MEG's been able to give her some insight into her current situation. I mean, psychologically, that should already make a difference in a way.
Yeah, and so the other case is a professional footballer who was just after 30. So he was considering playing for another 4 or 5 years. And he was playing in a weekday match, went up for a header with another player, and there was a clash of heads. And he felt concussed. And I think he actually stayed on the pitch for the second half, even though he wasn't feeling brilliant. But after he finished, in the changing room, he started to feel really ill. And he kind of had this progression of his symptoms over the next few hours and days, which is kind of a typical pattern that I see. And again, by the time I saw him, he was probably 2 years post that injury. And in this situation, he'd kind of limped along to the end of that season. With all sports people that I'm seeing, getting the next contract is the most important thing for them. The club wasn't happy to kind of extend his contract, so he ended up having to make a decision to leave that club, and then he could never really get back to any form of intense training, so he's had to retire. But again, similar to the doctor, no one was able to give him any clarity about what's happened. So he's completely well, extremely fit, an elite athlete, bumps his head, gets this set of symptoms, and then people are saying, "I can't work." But then no one says to him, and we think that the clash of heads has damaged the brain, which in turn is causing these symptoms. And so he's left, really confused about what's going on. And so again, with MEG, it was a very similar, it was a very similar outcome to the previous case. Now, the specifics of the frequency abnormalities that he had compared to the first case was slightly different, but the connectivity pictures were very, very similar. And again, for him and his wife and his family, the bringing clarity to the fact that we can see objectively MEG markers that suggest there's been subtle structural injury in the brain, and that's associated with the brain not being connected properly, which has to be the most plausible explanation for the symptoms, is a very powerful experience.
So as our thinking ability helps us to function in daily life, it's important to understand the mental health symptoms that should be a sign of something more concerning. So how and why does MEG data help you with your diagnosis and treatment pathways?
Yeah, no, I think so. So I think at the moment, there's two things that are happening in parallel. So one of the reasons why head injury has been so difficult for people to get their head around is because patients who don't recover have a broad set of symptoms. So they can have headache, dizziness, they can feel anxious, depressed, they can have problems with feeling tired, sleep disturbance, problems with memory. And all of us can have any of those individual symptoms anytime. So they're kind of non-specific. And as a consequence of that, people have been reluctant to use non-specific symptoms in a sort of way of kind of inferring the presence of something more significant going on in the brain. But what has happened in parallel to the developments in EEG is that there's people have tried to resolve this, and there's some really big studies now that are saying, hang on a second, if people have a head injury and a mild brain injury, and we compare those to normal people in day-to-day life or people who have an orthopedic injury, do they have more of these symptoms? And the answer's in, yes, they do. They have 3 times as many of these symptoms as either people who've just been in a nasty orthopedic injury, which is, either a nasty one, or normal people. So although they do have a lot of symptoms, it's now clear there is a specificity to these symptoms, that in using things like connectome MRI, we can then say, the structural abnormalities that we see in these patients are consistent. They then cause functional abnormalities in networks in the brain that are consistent. And wow, they map to the symptoms we would predict. So now MEG comes along and can say, now MEG will be able to do most of that, but it hasn't been applied yet. But it can then come along and say, so now we know that what we're looking for are these symptoms, and we know from using other imaging modalities that these symptoms make sense pathophysiologically. MEG comes along and says, here, you've got the classic areas of abnormality that infer the structural injury, and you've got the connectivity abnormalities that we see in the chronic phase, which suggests your brain is trying really hard to adapt. And with the two, at the moment, that is because that from a diagnostic perspective, I think is moving the debate forward quite a long way. Obviously, and my experience is that you have these patients who are kind of, left in the wilderness for years, and then you give them you apply this test, you give them results, and it's like, wow, thanks. But of course, the next question they ask me is, well, thanks for that. Anyway, get me better. And that's a kind of, and again, MEG is going to have a lot to help us. It's going to have a big role in helping us solve that next problem, but we're kind of not quite there yet.
Yeah, I guess the potential of MEG is not quite completely explored yet, really. But hence our next question actually is, so how do you think MEG technology will continue to influence neurological disorder care plans in the future? What is sort of next, I guess?
Well, I think that so we have to be honest about where we are with the condition, which is that there is this big debate about, what is the underlying cause of these symptoms. And I think that we're starting to make a lot of progress in terms of being able to say, does this individual person have the signature of a structural brain injury? So that's a big tick. Given that this debate has been going on so long, I've got a feeling we're probably going to have to go one step further, which is to take the people in the MEG and give them some tasks that provoke the type of symptoms that they're complaining of, and then we image them and we compare the way their MEG recording changes in comparison to how normal people's. And already some of that work is happening, actually, with the guys in Finland associated with MEGIN. So I think that in the diagnostic pathway, one is like this static imaging, which is brilliant because people don't have to do anything, you just sit there. So there's no one can say somehow the patient is manipulating the magnetic waves coming out of their brain. But there's still the challenge of, well, okay, so they've got those abnormalities, but are they causing symptoms? And I think the next step will be more work that says absolutely. Now, so the question was, for me, why didn't I really know much about MEG as a neurologist? And I'm going to be honest here, it's because neurophysiology in the UK, and it's probably not as bad in Europe, this isn't integrated into kind of neurological practice very well, and the potential role of the information you can get from EEG and MEG just hasn't got traction, which is a shame because now, 5 years on, I understand that unless we integrate into all neurological conditions oscillation and how oscillation is so central to how the brain works, we're really going to struggle to improve things. And so therefore, this is why I've kind of become really, really excited by MEG as a modality, because I think it's going to have, beyond the diagnosis and helping understand the symptoms, it's going to give us huge pathophysiological insight into how a structural injury causes a functional deficit. And that will open up targets for treatment. And by that, I mean, already people are thinking, people are doing deep transmagnetic stimulation, deep brain stimulation, trying to alter the way the brain modulates itself. But when you get underneath all of those techniques, what the modulation is trying to do is to revert the oscillatory performance of the brain into a more normal state. And I would never have said that phrase 5 years ago.
Well, it's nice to see you so enthusiastic about MEG. It's great. We've come to the end of of our time, so thank you so much, Steve. We really appreciate it, and it's been incredibly interesting to gain the insight into how you and your team utilize MEG. Yeah, really appreciate you taking the time today. Thank you.
It's a pleasure.